Welcome to Grantmakers in Health Closing Plenary, Public Health After COVID-19. What's our North Star? My name is Elizabeth Ripley, and I serve as President and CEO of the Mat-Su Health Foundation. We're a regional quasi-hospital conversion foundation serving the Matanuska-Susitna Borough in South Central Alaska. I have the privilege of living, working, and playing on the traditional lands of the Dena'ina and Ahtna peoples of Alaska. I also serve on the Grantmakers in Health Board of Directors. Throughout this conference, we've discussed or heard references to the erosion of public trust in science, data, and government institutions, including public health. Over the last 30 years of my career, I've watched state and federal funding decline for this field rooted in science, which has helped increase the American lifespan through research and data, physical infrastructure improvements, immunizations, health screenings, and disease response and mitigation. Our distinguished closing plenary panel features Dr. Celine Gounder, Senior Fellow and Editor-at-Large for Public Health at Kaiser Health News at the Kaiser Family Foundation, and she's joining us virtually. An internist, infectious disease specialist, and epidemiologist, Celine is a medical journalist and thought leader. She also serves as Clinical Associate Professor of Medicine and Infectious Disease at New York University's Grossman School of Medicine. Celine earned her Master of Science in Epidemiology from Johns Hopkins University's Bloomberg School of Public Health and her MD from the University of Washington. Also joining us is John Auerbach. John serves as the Director of Intergovernmental and Strategic Affairs at the Centers for Disease Control and Prevention. He has held senior public health positions at the federal, state, and local levels, from Health Commissioner of Boston to Commissioner of Public Health in Massachusetts, to 2 different roles at the CDC, including Associate Director for Policy. He holds a Master of Business Administration degree in Management from Questrom School of Business at Boston University. Dr. Brian Castrucci is also joining the panel. He serves as President and CEO of the de Beaumont Foundation, which advances policy and partnerships to strengthen public health. An award-winning epidemiologist who worked in 3 different state health departments, Brian is a fierce advocate for the public health profession. He earned his doctorate in public health leadership at the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. The panel will be moderated by Kara James, President and CEO of Grantmakers in Health. Prior to joining GIH, Kara served as Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. Under her guidance, CMS developed its first CMS equity plan to improve quality in Medicare and its first rural health strategy. Dr. James holds her doctorate in health policy and her bachelor's degree in psychology from Harvard University. Please welcome them.
Okay, so thank you all for hanging in here for this last session, and we are going to dive right in because this is another topic we could spend a whole week on. So, 2 years plus into a pandemic, 8 years after the Flint water crisis, nobody knows what public health is. How do we define public health? What is this?
Well, maybe I'll start. I think we probably each have different definitions. You know, as you heard, I'm at CDC now, but when I think about this, the answer to your question, I really think about it through the lens of having been a local health officer, because there I had to talk about public health not in forums, but on street corners and, you know, in neighborhoods where you really just had to be frank and clear. And so what I would say is it's about protecting the health and well-being of the public, particularly those people who are most vulnerable. And I would just keep it simple that way. The emphasis being on the public rather than on individual people, and what gets you more into healthcare. Focus on public health is on the public and on whatever it takes to promote health and well-being.
Mm-hmm. And Celine, you know, you deal in the media space, and so how does this come across for the public? How do we communicate this in a way that is, you know, that soundbite, but fits so that the public understands this?
Yeah, I think unfortunately coming out of the pandemic, you do have a slice of the population that thinks that public health is about telling people they have to wear a mask or they have to get vaccinated. It's sort of this nanny state idea. And I think we need to step back and help people understand that no, public health is really about understanding some health problems require collective action. So these are we problems, not I problems. And I think unfortunately in the media, the focus is very much a consumery health approach of, well, as one example, monkeypox is spreading, but what does that mean for me, as opposed to what can we be doing collectively, usually because this is running through the government, but also through community-based organizations and the like, to address these health problems.
Yeah. And so, one of the things as we're coming out of the pandemic, we're now pivoting a little, as Celine just said, to monkeypox. There's been a lot of stuff that has been happening. We had priorities before the pandemic in public health. And as we have pivoted to focus on addressing the pandemic for these last 2 years plus, we haven't been focusing on those things because we just couldn't. What were some of those priorities and what's happened in the intervening time?
Yeah, I think we know that right now our health departments took a lot of folks who were doing other issues, dealing with chronic disease, and moved them over to the pandemic. We have to recognize right now in public health that we are under assault. Okay, let's be super clear about that, everybody. We are under assault, and I'm sorry, John works for the government, so John can't say this, but I can. We're under the assault from the right, and it's not just firing health officials. It's closing needle exchange. It's taking away power from health departments. We are watching the erosion of public health. We have a whole group of political leaders who are taking a jackhammer to the foundation of our house. And you guys, every single one of you have, I don't care how much money you have, okay, your money is just not important. Because if we took all of our money and put in a big pot, it's not enough. But what each of you has is voice. And if we don't start using that voice, if we don't start looking at our fish tank and tending to the water and cleaning the tank, all the fish are gonna die. That's what we have in front of us as public health leaders. We cannot let all the fish die. We have to stand up to the right and start to say, it's not a bipartisan issue. Health is a nonpartisan issue. And Alan Keyes said, 30 years ago, 20 years ago? It's about the economy. It is about the economy, and the economy is on the shoulders of the health of our public.
Well, one thing I would say is it's never good to follow Brian. So, but what I also heard you asking was, have certain important issues like fallen off the radar screen? Yeah. And I think that's absolutely the case. I think the last couple of years, what we've really been focused on as a nation has been the COVID pandemic. Yep. And so that's gotten all the attention, it's sucked all the air out of the room. And so it also means that that's what people in the public think of if they think of public health. And the truth is, we have lost the vision about the importance of working on the wide range of different issues that are core to public health. For example, we're getting virtually no attention on chronic disease. How many of you the last time can you remember a really good, strong article about tobacco control or about obesity prevention or even about opioids, which a few years ago, that was everybody's area of attention. Are we paying any attention to heart disease, diabetes, stroke? And I would say we're not. We're just not getting the attention on those issues. And if we simply looked at what are the major causes of death in the country, we're just not focusing on those. We're not focusing on prevention. We've seen, as we've dealt with COVID, that if you have chronic conditions and other health issues, that puts you at much greater elevated risk during a pandemic, an infectious disease pandemic. But they've only been thought of in terms of the pandemic, not in terms of why aren't we preventing in an upstream way people from developing these other causes of preventable illness, injury, and death.
But John, and let me add, even when we do think about these preventable causes of death, when we do talk about them, we tend to view it through a medical lens, right? I mean, the fact that we can't differentiate between public health and health care. I mean, every single conversation that we have about health in this country devolves into a conversation about pills and procedures instead of policies and partnerships. And that's a word we've not said enough in this meeting. It's policy. It's policy. It's policy. It's policy. And I mean, Celine, as a media person, my favorite New York Times story ever was about Camden, New Jersey, and it said Camden has high rates of obesity. It has high smoking rates. It has poverty. It has all of these health challenges. Thank God they have a great cardiac service. Well, I mean, if that's our driver, then let's open some McDonald's and get people some heart disease so we can get them into the healthcare system. So I mean, it's educating journalists, and that's the beauty of Kaiser Health News, is you guys get it.
Well, to jump in here, I mean, we've had our own debates within the Kaiser Family Foundation as to what is public health. And I think a lot of people, even some of my colleagues, continue to confuse healthcare and public health. To me, the sign that whether you're healthy or not is really dictated by where you live, that your zip code is the best predictor of your health, clearly shows this is not just about you as the individual or even your access to healthcare, but that the drivers are much broader. The other thing I would add here is, from a media perspective, they call it the news. They want something new. And so that means that for those of us who are trying to get the word out through media, who are passionate about public health, we do need to find a way to tell these old stories with a new twist. So how do we get people to view obesity in a new way? I mean, I started my career working in tuberculosis, which is one of the oldest diseases out there, and it's really challenging to give a new spin to some of these things.
Yeah. Can I just mention one other thing, though, that you made me think of in this discussion? Brian, you mentioned Camden, New Jersey, and what I thought you were going to tell the story about was the screening effort that was done in Camden, which showed that there was an elevated level of hospitalizations and emergency room visits for people with asthma. And they did an analysis, you may remember this, that determined that there was an unusual concentration of those cases within a 1 or 2 block area. And it turned out they were in the buildings, certain buildings. And then public health people went in and found out, well, the reason that people were being hospitalized for asthma had to do with the conditions within the building, and whether or not the paint was peeling off the wall, whether or not the environment was causing the problem. It wasn't a clinical problem, it was an environmental problem. Now there, I think, the way that it was handled was, okay, now that we know that, as we're providing clinical care to people, let's try to have the patients that are the most sick have a home visit. I think that missed the point. I think the point really should have been, if we pay attention to the environmental conditions, the social and economic factors in people's lives, that's going to have a much bigger impact than if we pay attention simply to, are they getting good clinical care? And so I think one of the things we have to do in terms of rethinking public health and thinking about the future is really move away from a disease-specific approach to thinking about how do we change the conditions in people's lives, the social, economic, environmental factors, so that those are ones that promote optimal health instead of impede optimal health by all these barriers to what will make people healthy.
Well, John, it's like that. Remember the old Lucille Ball episode where she's in the candy factory with Ethel? And the candies keep coming, and they're doing everything they can. Do you ever wonder why no one pulled out the damn plug? Because that's healthcare, right? I'm going to go tomorrow with my kid who has asthma. I'm going to hit the ER, and then I'm going to miss work, and then I have to follow up with my pediatrician, and then they're going to give me something. They're going to break, the asthma for that moment, and then I'm going to go back, and then I'm going to go back, and then I'm going to go back. You got to fix the HVAC in the apartment building where I live, and we are resistant. And John, you said it. Celine, you said, we have people who still are debating the difference between health and healthcare. You said, we all probably have our own definition of public health. We can't continue to have our own definitions of public health. Public health is not a snowflake. It's not unique in every single one. And even the fact that in 2022, after a pandemic, you can even ask the question, what is public health?
Right.
Because if I asked you all to draw a hamburger and then share that with each other at your table, it's all going to look the same. We know what a hamburger is. We have the brain architecture for a hamburger. But y'all are geniuses. You're public health leaders. Now draw public health. What would that look like? Would you even be able to do it? And until we create the brain architecture, I mean, there's probably not a Trump voter among us, but what did he want Hillary to do? He wanted to lock her up. What did he want to do on the southern border? He wanted to build that wall. What's public health? 40 minutes later. And that's public health.
That's right. And this, I think that is, yes, you can applaud that. Because I felt for a while, public health needs a branding campaign. Because if we can't explain it, we can't get the support that we need to fix it. So let's pivot a little to how we fix this. Coming out of the pandemic, and public health is broad. You know, the Commonwealth Fund just had the commission, their public health commission, that came out with their report, and they go back to the IOM definition in 1988. That's a really broad definition that we are coming together to create the conditions that people need to be healthy. And it's sort of like that, okay, that's broad. So the chronic conditions, the top diseases that people are dying from, the challenges that we have, we moved on to monkeypox, not quite because we're still dealing with the pandemic. What should our priorities be? What is our new North Star that we should be thinking about for public health that prepares us for the challenges ahead, that's built for the long game and to achieve for everyone?
Well, there are a few things just to pull out of the Commonwealth report. So first of all, we do not have a national public health system. There is not one person you can point to as being in charge of public health. CDC is not the national public health system. And I think CDC has come to mean public health writ large. In fact, even among federal agencies, you have many other federal agencies that also have authority over public health, whether that's ASPR or the FDA or OSHA and so on, or the EPA. So I think, one, we need to find some way to have more coordination within the federal government when it comes to public health, have somebody who is truly in charge, and then also have more coordination and collaboration with the state and local health departments. Each are, in a sense, their own siloed public health system, and that really is not a national system. I think in terms of our North Star, in addition to thinking nationally, there are very basic elements of our infrastructure that need rebuilding. So workforce, my colleagues at Kaiser Health News in a series called Underfunded, Under Threat did a wonderful job of documenting how healthcare workers have been fired, retired, quit over the course of the pandemic and have not been replaced. So we are coming out of the pandemic weaker than ever. The one bright light I see in that is some of the developments around community health workers, which we can talk about later. We also really need to work on our surveillance and laboratory capacity. Why is it that the CDC is reporting case counts by state for monkeypox? If you look at the European CDC data, they have all kinds of demographic breakdowns. They can tell you, well, we've had 10 women with monkeypox. We have no idea here in the United States if any of those cases are women. And so that's something that really needs rebuilding. And then finally, data, the data infrastructure. And all of these things that I'm talking about really underlie your ability to respond to the whole range of infectious diseases and chronic diseases and the like.
So if I was starting to think about this, I would say that from a public health perspective, our starting point should be looking at the communities that are affected and asking the communities to be at the table with us, identifying the priority health issues. We should be starting by looking at data and starting by listening to communities. That's not the way we operate now. Public health is funded as a categorical disease or condition-specific activities. You know, when I was a local health officer, I had 100 line items in my budget, 100. Each one of those represented a very distinct issue that I had to work on. I had no ability to move a dollar from one line item to the other. It was tobacco, HIV, infant mortality, STDs. So I didn't decide if I went to a community meeting and people said, as they sometimes did, why aren't you focusing on housing? Why aren't you focusing on healthy housing? I had no money to do that. I could only say, well, here's the line items I have. If there's a disease associated with housing, I might be able to work on housing, but only for that, reducing that particular disease. So I think the new North Star would be that the starting point needs to be listening to the community and looking at this data-specific community, data-specific issues in a community, and then focusing as much as possible on upstream rather than waiting till problems become already significant ones and you're just trying to reduce the risk. Getting to that new North Star requires a different way of getting funding. It requires a different relationship with the community where you're not the expert, but you're at the table with the community members, and it involves thinking broadly about public health, not disease specific, but about changing the conditions.
Mm-hmm. Policy, 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 then some policy, and then do some more policy. I hope everyone goes to visit cityhealth.org. It's 12 policies that are evidence-based. These are not controversial policies, they're policies that every city should have. We went into a pandemic as one of 2 industrialized nations that don't have a national paid sick leave requirement. So that's policy. We can fix that. We can work on those things that define the parameters by how we live our lives. Shakespeare said, all the world is a stage and the men and women merely actors. What he left out was policy defines that stage. And so we have to, as philanthropists, begin to get uncomfortable, begin to kind of cozy up to that advocacy line. Maybe cross it every so often, and we'll apologize and step back. But we have to start thinking, what are the policies that we have to take on? Because Celine's right. There is no national public health system, right? The founders got it wrong. The founders got it wrong when they didn't put public health in the purview of the federal government. We watched through COVID in Georgia. We watched Governor Kemp open up restaurants and bars while his health official was trying to hire contact tracers. Those things were working against each other. And we sit in the state of Florida right now, where the health official is spreading disinformation, where the health official is telling people not to get the kids vaccinated. And in Virginia, we just saw the state health official say that racism's not a public health problem. The playbook is clear. Those who seek to assault public health and undo the gains that we've made in life expectancy, they know how to cook the system for their benefit. We, in philanthropy, with our communities, have to stand against this. The stakes are amazingly tremendous. And we're going to live in a world where health is a luxury item. And we cannot stand for that. I had a heart attack a couple months ago, and I weigh less, and I'm healthier, and I get my meds, and it's all because I'm a straight white guy who's rich. And that shouldn't be the prerequisite to health, but it is.
So that's actually a good segue, and I'm going to come back to our funding, because this is an issue as well for public health, but I want to touch for a moment on the equity issues that we have seen arise. I mean, the pandemic, you just fill in your blank, highlighted cracks in whatever you want to fill in. Equity being one of those, and equity has always been a focus of public health, and I think even more so now. And yet we are, because of the environment that we are in, the playbook that you just mentioned, there are attacks that are happening with it. How do we maintain that focus on equity? Also, given the news cycle that Celine mentioned in terms of wanting things to be new, and inequities are long-standing. So how do we maintain that focus and push forward in the time?
Yeah, there are 2 things I would advance on that front. I'm curious to hear what John and Brian also have to say on this. One, just like the Biden transition COVID equity task force identified, you can't address inequity without having data. And this goes back to what I was saying earlier with our epidemiologic surveillance data. Nationally speaking, we have tremendous weaknesses in that. And not all states are collecting data on race, gender, socioeconomic status, et cetera. And so it's impossible to do these analyses at the national level without that data. I think another real challenge here is as John was saying, we need to be at the table with community-based organizations and community leaders. But many of these community organizations are unable to access federal funding, public health funding, because they simply are already running on a shoestring budget. They don't have the capacity that, say, big academic medical center might have to apply for that kind of funding. So if you really want to make things more equitable, some of that will mean helping community access that funding to fund public health interventions on the ground.
Yeah. I totally agree with Celine on that. I would also say that we need to make sure that we are shifting our thinking about equity from where it used to be. Where it used to be when I started out in public health, I think we realized that there were disparities. So we talked about disparities a lot. And what to do about disparities. But we did not, as a sector, talk about racism. We didn't talk about systemic racism. It just wasn't part of the way people talked in public health. And so I think part of the new North Star, if you will, and I think part of the progress that's been made in the last few years is to really start by talking, and understanding systemic racism and making sure that that's part of core public health. I think part of the progress we've made is we have health departments across the country who are saying racism is a public health issue. Dr. Walensky at CDC did that. I think a terrific leadership where she, more than a year ago, declared for the first time by CDC that racism was a public health threat. I think that has to be part of the answer. Because if we have too narrow a focus, if we see, there's a gap between this versus that health outcome, it doesn't allow for a full understanding of what can be done. If we're talking about food insecurity, for example, and our solution is, here's a bag of groceries and there's a kitchen you can come back to each week, that obviously doesn't solve the problem. We've got to figure out what is behind food insecurity in this example, or unstable housing, and how do you change the policies? You'll like this, Brian. It's really about policy change, so we don't have enforced legal segregation, so we don't have the inability to get a fair and good education or a fair and good job. I think part of public health's work is to think in terms of those kinds of approaches and policies as core public health, and not only, we've got a gap in infant mortality. That's the result, but the cause is really by looking upstream and looking at systemic causes.
Yeah, I mean, John's right. We're not going to undo centuries of racist federal, state, and local policies with programs and interventions. Those are Band-Aids. We need to make policy changes. We need to change the rules of the game if we want to have different outcomes. And from our team at DeBoma, Brittany Giles-Cantrell is sitting down here. And you can talk to her about work that we did with Gail Christopher and APHA called Healing Through Policy. It identifies policies that local governments can enact that will advance racial healing. Because remember when everybody was making statements that racism's a public health crisis? Remember that? Every day, this group, that group, 240 local governments have made this statement. Well, then what happened? The temperature went down and everyone went back to doing what they usually do. And so we have to really, as philanthropy in our communities, working with our communities, hold our health departments accountable. Don't ask them, what are they doing with health equity? Have them show you. It's not that we can say the word. We've taught everyone to say health equity. What does your health department do? It does health equity. What does that mean? Dr. Jamila Porter and I were working on a paper last night out of our PH Wins data, which is a large national study of the public health workforce, and there is state and local data in it as well, which we can give you if you are interested. And it found that really we have heard about the social determinants of equity, but we have very little confidence as health department practitioners as to what to do about it. And that's something that we in the community must lead on. What are we going to do about it? Saying it, and you know, not to put the good Dr. Walensky on the spot, but you know, it was good for her to say racism's a public health crisis. But all it amounts to right now is a slogan on a t-shirt. What is it going to mean? How does it change NOFOs? How does it change the way that we can use our money when it's siloed? That's what we have to get to, is what does it mean? How are we going to get change? Not just lip service.
And I would add to that, going back to Celine's point, how do you measure it? Because if we don't have the data to measure race, ethnicity, we talked about even yesterday in our session on LGBTQ and racial equity, you know, pulling back on data to be able to measure sexual orientation, gender identity, we have data gaps, and those are the ones we know how to measure. Racism, like how do you measure racism, which we could have a whole other panel on.
But Cara, we need to be clear that, and I don't want to lose my epidemiology card, right? But you know, we have to be very clear that data are the original sin. Our data are not without bias. We talk about data like it's pure, and it's like white-driven snow. It's like just great if we had the data. Those data have bias cooked in from the minute that they're collected. And so we're often using biased data to show progress, and it doesn't show it, it shows things differently. I mean, we use data to perpetuate victimhood or marginalization. So we have to be thoughtful. And I'm an epi, like I love data, but if it's raining, I don't need data to know that I'm wet.
It's true, but data is also used, and we're going to derail the whole conversation on the data because we got the data nerds up here, but data is also used to not take action. Because people will say, well, how large is the problem? We don't know, or we don't have good data on this, so we're not going to take it. It's a crutch. And I've been in plenty of conversations where, I won't say where, but you know, in conversations where people will say, well, we don't have the data. Specifically, well, you know, it goes back to the Medicare race and ethnicity data problem. And so we don't act. And to your point, I don't need to step outside if I can see it's raining from inside to get wet to know that it's raining. We have a problem, let's work on it. But I think that is one where data is not perfect, but data is helpful, and the lack of data, particularly when it relates to equity, is something people will fall back on not to act.
I agree with that. I don't think we should revoke your card, but I do think that the data, I don't think you're saying this, but I think data's not flawless. There's so many gaps in our data now that we really have to plug. I mean, when we started the vaccination for COVID, we were collecting 50% of the reports of who was getting vaccinated. Only 50% had race and ethnicity. 50%. And it's higher now, but it's not 100%. And then if we move to another condition or illness, we'll be back at that 50% level again. And then there are other things we're not even asking. So among the things we're not asking, I know you agree with this too, Brian, because you would want this kind of data to be collected. But I would say we're now noticing, for instance, as we're working on COVID, we don't have good data on people with disabilities. So we know from anecdotal information and some other data that we're gathering that people with disabilities are at elevated risk in terms of poor outcomes from COVID, but it's not routinely asked. And we also don't know, we don't have good data on income. We really just don't, you know, other countries actually have data on income, and then you can do sort of an analysis about poverty. We use these surrogate markers like, are you on Medicaid or not? That are not really the best kind of data. So I guess I agree with both of you. I think we need way more data, but we need to make sure that it's meaningful data and that it's also interpreted correctly.
So as we move from the Health Services Research Conference back to the Health Funders Conference, for our health funders in the room.
Wait a second, wait. I want to just go on a second. So I looked for some shoes on Google. And for like 2 weeks, I got ads about shoes. So it's not a data problem. It's a political will problem. Like, we just engaged in robot tourism, for God's sake. We sent a robot to Mars. It got out, it took some pictures, it sat by the pool, and it came back. So this is not a tech problem. We know how to do this. We lack the political will to collect the data that we need. I mean, this is, Abigail Echohawk is brilliant on this topic around, how we even collect data. Let's be super clear. All of the messaging that we did in COVID, and I'll speak for de Beaumont on this, it was a 1,200 person random sample. It didn't get to our communities. It didn't get to our nuance. We've lost all of that in our data. We have to not collect data for the sake of data. We have to mobilize political will to solve problems, and data are a key part of that. But this is where we've just lost our and for everyone here, what we need, if we could do one thing coming out of this conference, we should all work together, working with maybe Kaiser Family Foundation or another national organization who could do a national public health poll to have an understanding of how people think about public health. And then each of us, whether we're state-based or whether we're local, we can just oversample our communities on that same poll, and then we would have a plethora of knowledge for what we should be doing in public health, and we could bring some unanimity to what we are doing. But right now, our behavior as health funders is often like the Tower of Babel. We each are doing our own polls with our own methodology to come up with our own data, and 2 foundations in 2 neighboring counties will do 2 separate polls that are not comparable. And so we never understand where we should be going, and if you don't know where you should be going, you don't know when you're lost.
That's great. And I want to, so I'm going to open this up for questions. I'm going to ask you guys one more question. But again, if you're joining us virtually, you can type in your question. For those of you here in the room, we have a microphone in the middle, or if you would prefer to have someone bring the microphone to you, we have a couple of people on the team who will bring the microphone if you just raise your hand. So as we're queuing up for questions, one of the areas that we have not had a chance to kind of delve into, but Brian, you're alluding to this, of how do we as funders work together more strategically to magnify our impact. And also, we have CDC here. How do we work together to foster those public-private partnerships to move forward?
I think that we have to be mindful not to duplicate efforts. So Brian gave the polling example, and Kaiser Family Foundation does, the gold standard quality of polling, but there are other things we may not do as well. So we don't have the epidemiology capacity to do what other groups can do. And I think it's really important to develop those partnerships, those collaborations, so that we're not reinventing the wheel within each organization.
Well, I'll say in terms of public-private partnership, I don't think we do enough of it, and I don't think we're as thoughtful or as creative as we could be. I say as a local and a state health official, I didn't even think I could apply for philanthropic dollars. It was like not something the city and state kind of knew how to do. We were just like, all we could do would be to try to manage the money we were getting from the state or the federal government. And I think that meant we missed opportunities. We missed opportunities for creative partnership and thinking outside the box, thinking differently than the way the sort of government can sometimes think with blinders on. And I guess I would say the same thing's true with CDC. I think we would, I think, like the opportunity to be thinking creatively with you. Are there things that we can do in government in partnership with you that maybe where you're doing things we can't get away with, we're not allowed to do, but where we've got some capacity that maybe could complement your doing innovative approaches, thinking outside the box. I'd like to think about how to do that. Although I'm not exactly sure what the ideal forum would be. Maybe Grant Makers in Health is the ideal forum for pulling that together.
Well said. I'll put your check in the mail when we're done. Thinking about that though, I think one of the barriers, and I really kind of want to probe the two of you on this, and as well, Celine, from your perspective, You know, John, from your perspective as someone in the government who's been in the government several times and worked at different levels, what do you think that health funders and philanthropy needs to know about government that would make it easier to work with them? And Brian, similarly, you know, sort of on that side, what are some of the biggest challenges and what are the things that we think people need to know more about to foster more of these relationships?
That's an excellent question. I'm going to start to think about that. And Brian's also worked in government, so he'll think about that too. What I think is people in government, I think, would like to work with philanthropy and just don't know how. That's one thing. I think they don't quite. You know, if you've worked in government for a while, some of you may have worked in government, you're like used to being a rule follower. There are these rules, and you know, if you're doing something that hasn't been done before, it's, you know, you can get into trouble and get your hand slapped a lot. So, but I think that the truth is, the people in government from the highest level to, you know, throughout the organization, I think there's a real interest in thinking that way and learning and trying to come up with creative approaches. So I think the welcomeness exists. It might appear that it doesn't if the spokesperson for the agency is not that receptive. That doesn't mean there aren't lots of people inside that really want to figure out a way to work together.
Mm-hmm.
Yeah, I think we have to open up ourselves as health funders and be clear about what our role is. We have no rules, right, except the lobbying thing. But we have no rules. And so we have to work with this group that does have a lot of rules and figure out how we can facilitate their agenda without a clear direction to do so. So we have to figure out how to work better with our governmental partners where we may be pushing something that it might even look, and I've done this at times, where I'm saying something that looks like it's against a health department. Now, what no one knows, though, is that I got a call from that health department official who said, I need you to say this. We have to be that friend. We have to be that partner. Because again, our voice and our influence is far greater than our funds. And as we watched health officials get terminated, as we watched county commissions turn on nurses, if we were silent, then we were complicit. You know, the greatest call I got during the pandemic was from Pat Matthews at the Northern Virginia Healthcare Foundation, who's been on the board. And Pat said, Brian, have you seen this article about how they're blaming the nurses and they're blaming the health department for not hiring nurses quickly enough? We need to say something about this. And we wrote a piece to stand for our health department. And we need to stand for our values. We can't be those people in that fancy office somewhere anymore, right? When we talk about promoting inclusivity and promoting diversity, this does not mean in fancy suits at the Lowe's Hotel. It means we got to get dirty. We got to get with our community. We need to be there as partners. You know, peanut butter is great and chocolate's great, but what's really great is when you put them together, right? We have to figure, we can be the peanut butter and the community can be the chocolate, but together we got to make the Reese's.
Mm-hmm. Yeah, so we have, just checking to see if I have any hands up. If not, I'm going to hold, I have a question from Allison Bauer that I'm going to hold for our end question because I think it is a good way to lead us off. But we do have, you know, Brian, going back to your point of collaboration, another question from one of our virtual participants, So, who is a public health researcher who wants to know how can funders get more coordinated? You know, yesterday someone mentioned the 50 priorities for philanthropy. So how do we get ourselves a little bit more coordinated internally to help foster all of this?
Well, I think Grantmakers has a real key role to play there. You know, bringing us together, you know, getting us. I mean, it started to happen during COVID, and it was one of the more rewarding things during COVID, where people were coming together around a table. Not necessarily to say this is how we need to change what we're doing, but at least all of us hearing what each other were doing. You know, so Kaiser Family Foundation and de Beaumont both do polls. We do very different polling, right? We were doing push polls. Kaiser Family Foundation was doing more of the gold standard. So that was great, and we knew where we were different, but we were able to say, like, look, this is what we're going to put on the push poll for tomorrow night. When you actually do the sampling the more professional way, maybe you consider putting this same question, and we can then look. But we need to talk to each other. I mean, You know, we come here and we meet with each other and we have a good time, and then we go back home and we kind of go back into our silos. And we have to really work hard to create a community of philanthropy. And I do think that's a critical role with GIH, and I think you've done it with child funders, but maybe it needs to pivot to public health funders, and again, everything's public health. So, you know, all of us, how do we align better? You know, maybe it's all of us giving GIH a grant to do some polling, and you can subcontract with people just like we could, but you could bring that unanimity. I mean, we all need to read Horton Hears a Who if we've forgotten it, right? It's all the Who's speaking together saved the speck. If it was just one Who, no one heard them except Horton. And damn, we're running out of Hortons.
Okay, got a question back here.
Buenas tardes, mi nombre es Lourdes Rodriguez, and I serve as Senior Program Officer for Women's Health at St. David's Foundation. John and Brian, you all know I love you very much. Celine, I don't know you personally, but you look like a very lovable person. So please don't take offense at what I'm about to say. 20 years ago, right, when Kamara Jones was raising the alarm about racism as a public health issue, it was like a sole voice in the desert, right? And, you know, she even wrote the book, right? Or she wrote a chapter in the book, Racism, Science, and Tools for the Public Health Professional. How can we elevate the scholarships of scholars of color in these discussions? Because we have been saying this for a really long time, but our scholarship is not cited, it's not brought up as part of the expert discussions. So as, you know, in your position, how can you help bring that and build on it, as opposed to think about how innovative a statement as racism is a public health issue sounds now, when 20 years ago, a woman of color said it?
You know, I think that you're talking particularly about scholarship. I think that the issue is making resources available and shining a light on the research that is being made now to try to highlight the researchers and the conclusions, and not just in journals, but where the studies and the writings exist. So, and then I think we need to be thinking about the next generation, who's in training now, and how to make it attractive to go into the field, so that there's continual contributors and new researchers that are seeing it as a career they can build, a career that gets support. So that would be some of my initial thoughts. But Celine, Brian, your thoughts?
Yeah, I mean, I think, first of all, at public conferences like this, just as there has been outcry over panels, including only men, and I've seen this even very recently at one of my own home institutions in New York City, where it was a panel on the history of the HIV epidemic in New York, and it was, I think, 6 men, and all white men, by the way. So I think there needs to be attention paid to that by conference organizers. I think similarly in the media, and I do think if you look at who has been on air, for example, on CNN or MSNBC, and this is something I spoke to some of the producers about, hey, you should invite so-and-so on this topic, or you should talk to my friend and see about having them on. I think we do need to be intentional about trying to bring some of those voices into the lay media. And then also, as John alluded to, people in training. And I'll just highlight one such step in the right direction. And this is really in large part due to advocacy by my friend, Dr. Kaf Daraza, who's at Duke, a neuroscientist who has been pushing the NIH to find ways to make funding more available to underrepresented minorities. And there is a brand new R01 for investment in neuroscience research that really is focused on underrepresented minorities. And that includes, for example, people who have a history of homelessness. It's not just about race. but understanding that many people have had difficulty having a seat at the table, having an opportunity to even do this research, much less be cited for their research.
Yeah, I mean, a seat at the table I think is important. We got to burn down the damn table and start over. And that's, you know, part of the problem is we're built, and listen, I am not a health equity expert. I learn every day. I learn from my team, I learn from my staff. I'm a straight white guy, so I'm learning, right? And my role here has to be to create the spaces where that scholarship, because we all heard Kamara when she said it, and no one did anything about it. And so we need to be deliberate in creating the spaces and centering equity. That's, if you've never seen it, I hope you will look at the 10 essential services of public health. It centers health equity now.
Yes.
Do you know that before 2020, the old 10 essential services never made reference to disparities, never made reference to equity. And so we have to hold ourselves very accountable to creating spaces where we are centering voices that can fill out the space and that can be prioritized. I mean, you're right. The fact that we're just getting around to racism as a public health crisis is, you know, kind of, it's bad on us, right? I mean, we knew this. We've known this for a long time. We knew this in the 60s. We knew it in the 40s. We knew it in the 1800s. We've known this. And so we have to figure out how we can get to where we want to go with health equity. You know, figure out the policies, figure out the scholarship that we need, and then begin to work on some of those systems like the NIH R01 process, which is daunting, right? And giant research universities know how to do it. They know how to play the game. But again, we're not going to get different outcomes until we change those rules a little bit. And I do know NIH is taking some very deliberate steps to figure out how we can ensure that the pipeline is there. But we, as health leaders, as health philanthropy leaders, we need to look at every aspect of our grant making, of our contracting, of, again, who we put at these conferences, and making sure that there's space for other people, and not just have the conference or the scholarship, but what are you prepared to do about it?
Yes.
Right? What are we prepared to fund? How are we prepared to do it differently? And again, I am learning every day, and I'm grateful for the team that I have at DeBeaumont willing to teach me stuff that I probably should have learned a long time ago. But this is the struggle, and we have to go forward and figure out how we make the change we want and what that change looks like, and then begin to align our assets and our resources towards that goal.
Thank you.
And I would also add, I mean, as someone who's been in the health equity space for a while, there are a lot of people who are coming into this space, and you talked about, you know, what is the definition of, we could have a whole conversation, what's the definition of health equity? And I think for those who may be entering the space new, you know, 2 years ago when I wrote about enough is enough, it's time to get serious about addressing health equity, one of the things that is important is that we approach this with cultural humility. Because there are people who have been doing this work for decades, such as Kamara, such as Lisa Cooper, such as, I could go on and on, Neil Poe, I mean others. And it's not that their scholarship is ignored, it is that others are coming in and thinking it's kind of new, you know, and it's newly discovered. So with every problem, we all do that literature review. Do your literature review, figure out who's in that space, partner with them. Lift up, because that's how we learn and work together. And it has been, you know, it's personally, it's been challenging to watch folks coming into the space who are getting resources. And as one of my tribal colleagues said, you know, people calling them to pick their brain, but as they call it, mining and exploiting, because they're mining and exploiting them, picking their brain, and then going and getting the grant and the research dollars to do the work. So just let's be a little humble as we're entering these spaces and all of this. So as we end this, coming back to our public health, quickly, sorry, one last question and then we'll close us out here.
Thank you, Cara, and thank you all for your remarks. I want to take this back to the community and how communities really are defined beyond their diseases. And to talk about, you know, what you said, Brian, about mobilizing people to solve problems and partnerships between philanthropy and government. So if we think about this in terms of public will building and mobilizing public action for accountability because at the end of the day, I think what we're talking about is holding government accountable. There's an inherent tension, and so I'd like to hear you both, all of you, speak to the inside-outside strategy. It won't happen just through partnerships that are very polite and collaborations. There has to be a demand. What do you say?
Yeah, I would say this is one of the reasons community health workers are so important, because they can be, if this is done right, that layer coming from the community that's interfacing with various public health officials and holding them accountable. I think part of the power of community health workers, again, if done well, is that they can be trained up in leadership skills, in civic skills to help organize their community. And it could be something as basic as organizing to get a walking trail. It could be organizing to put pressure on NYCHA in New York with respect to apartment buildings that are really in bad shape with respect to quality of water or lead paint, or whatever the issue is. But I think having an intentional effort to train up that layer of community leaders who are from the community, who have the trust of the community, is one step in the right direction.
We talk about public health departments partnering with the community. They need to employ the community. They need to have positions in the health department that are for people who have a lived experience, for people who understand the community and can navigate the community. I mean, listen, I'm a damn fine epidemiologist, but I don't have the same community experience that someone else does. So again, if we can have that partnership, have community and pay community to be at the table when we create our data collection instruments, this is how we begin to not just have that polite partnership, but each have skin in the game. Why do you have to be an MD in some places to run a health department? Why can't you be a member of the community? Why can't you be someone with lived experience? And that's another, barrier, formal barrier to leadership in our health departments, requiring MPHs or DRPHs. And listen, I'm all for a DRPH, but I also want to make sure that when we are sitting together as staff in a health department, that we have all perspectives represented, and I don't think that's how it is right now.
Well, I would agree with the question you're asking and the responses, but my one additional point would be, I don't think we can hold people accountable if we don't give them the tools to be able to do the right thing. And I think public health over the last 2 years has gotten blamed for a lot of things where public health was the victim. But they were having fingers pointed at them for not having enough resources or not being prepared for a pandemic. When really the root of the problem was how the funding going down, the roller coaster level of funding, the restriction to disease-specific approaches. So I think we need to give people the tools and resources and then hold them accountable. But I think it's got to be hand in hand that we really have to pay attention to both.
Well, Brian, Celine, and John, I want to thank you. I want to end because as we go off, we do need our public health branding campaign. So next year when we gather to talk about our next step on building our North Star, we got a question here, Brian. What is our public health description that's akin to build the wall that we can put on our t-shirts?
I don't know. Because there are people who are skilled in this. And what I do know is that the De Beaumont Foundation, and we're seeking partners in this, we're gonna work with some of the nation's leading communications firms. Yeah. And we're gonna try to come up with this, but we need to do the research. We gotta put in the time, we gotta do the focus groups. And it can't be something that just resonates with Democrats or just resonates in San Francisco. I want something that resonates with Republicans. I want something that resonates in Alabama. I need people to understand that our future safety, security, and economic prosperity is in the balance, and that those things are predicated on us being healthy. There's almost nothing you can do. You can't go to school and do well, you can't graduate, you can't show up at work, you can't worship if you're not healthy. And so until we recognize that health is central to our existence, we are going to keep falling backwards. The fact that we are continuing a 50-year debate over Roe v. Wade, where we are actually telling people that they can't have health care, and the impacts to public health are being minimized by one side of the aisle. We are under assault. Maybe that's our 3 words. We are under assault. And the only people who can fund that rebellion and that resistance are the people in this room. That's your job. Take it seriously. Do the work.
Thank you. And with that, I want to thank Celine, Brian, and John for an excellent conversation. Thank you so much.
Thank you, Kara.
Thank you.